Hello, everyone. Welcome to the Disability Employment Technical Assistance Center webinar, Advancing Competitive Integrated Employment Through Managed Long-Term Services and Supports. It is now 3 o'clock, time to begin. My name is Donald Taylor, and I am one of the technical producers for today's event. Before we begin, I want to call your attention to a couple of accessibility features today in Zoom. All of the features are available from the Zoom menu at the bottom or top of the Zoom window, and they only become available when you move your mouse over the Zoom window. The little menu will slide up from the bottom. Or if you're using it on your mobile device, you have to swipe to get to the controls. First of all, we have 3 requests for our speakers. You will see that we have an American Sign Language interpreter spotlighted for all attendees, so that the other person showing is the presenter. We ask that when you are not speaking, you turn off your microphone and camera so that what shows is the ASL interpreter and the presenter. Since we have ASL and Spanish interpretation and captioning today, we ask that you slow down in your speaking a little bit to help them keep up in this complicated work. Since we have visual and hearing impaired attendees, we ask that when you begin your part, you identify yourself and make a brief description of yourself. And if there are any key illustrations in your slides, we ask that you describe them as well. So, I am Donald Taylor. I am a white man with dark COVID-19 distancing hair, wearing a maroon V-neck sweater. Behind me is a dining room dry goods shelf and some hanging plants. There is an American Sign Language interpreter as the pinned video to the right of the shared slide. If for some reason you are not seeing the ASL interpreter, make sure that Zoom is in gallery view. So roll your mouse over the Zoom window. In the upper right-hand corner is a button labeled View. From View, choose Gallery. If you're still not seeing the ASL interpreter, please let us know in the chat and we'll do what we can to help you. Captioning is available for today's Zoom session using the in-Zoom captioning function. At the bottom of the bottom menu to the right, there's a CC button. If you click that, it'll turn on the closed captioning in the Zoom window. We also have Spanish language interpretation as an alternative audio stream. When you choose Spanish, the English audio will be, so there's a button that looks like a globe. If you click that button, it'll give you a choice of what language. You choose the Spanish. The English language audio stream will be reduced in volume to 20%, and the Spanish language will play over it. To access this, if you want to completely mute the English audio, there's an option to do that. Also, if you click on that interpretation menu. And now Amy will say the same in Spanish.
Si desea escuchar la presentación en español, consulte la guía para seleccionar la configuración. Coloque el mouse sobre la ventana Zoom, usando el menú emergente de la parte inferior de la pantalla. Una de las opciones a la derecha es Interpretación. Haga clic en ese botón y seleccione la opción en español. Si desea silenciar completamente el audio en inglés, hay una opción para hacerlo también en el menú Interpretación. Turning it back over to Donald.
You can control your individual volume settings in Zoom, also from the Zoom menu. Move your mouse cursor over the window. All the way to the left is a button with what looks like an old-style tabletop microphone. In the corner of that button is a very small up arrow. If you click on that up arrow, you will get a menu that will allow you to control your individual sound settings, and you can adjust the volume using the slider. We will have a question and answer session at the end of today's presentation. You can pose your question using the Q&A box from about the center of the Zoom menu. Be sure to post your question in the Q&A box, not the chat box. We also have a chat box, and sometimes the chat box gets moving quite quickly, and if you put your question there, it will have been lost in the scroll by the time we get to the Q&A, whereas the Q&A box gives us some tools to make sure that we don't lose your question. If you need assistance with any issue during this webinar, I'm going to mute my microphone and turn off my video, so I'm going to disappear, but I will be monitoring the chat box throughout. So if you have any need for assistance, let me know there and I'll do what I can to help. This session will be available as a recording and a transcript. As soon as we get them posted, we will email all attendees with the link to where you can find the video and the transcript. And now I'm going to turn it over to Amy Gonzalez, who will introduce today's presenters.
Next slide, please. Thank you, Donald. Good afternoon, everyone, and welcome to our second webinar of 2022. We are delighted to be here with you today, and we'd also like to thank our speakers and our self-advocate for joining us today as well. I'm going to briefly go over the agenda. I will introduce the speakers, and then I'll turn it over to them. Today, we are going to hear from Dr. Lisa Mills, a national expert in Medicaid, working to advance competitive integrated employment for people with disabilities across the country. She's going to give us the national landscape, and she's going to help us understand more about long-term services and supports. Move that to the previous slide, please. Next, we're going to hear from Dr. Yasmina Barawi from the Michigan Council on Developmental Disabilities and how they, as a grantee, have really paved the way in the state of Michigan for managed long-term services and supports. We're also going to hear from Inclusa, Inc., a managed care organization who is creative, who is innovative, who is paving the way for competitive integrated employment. And then we have a self-advocate with us today who will share his journey to employment. As Donald stated, my name is Amy Gonzalez. I am the project manager for the Disability Employment Technical Assistance Center. I am a Latinx woman under the age of 40 years old. Today, I have my hair down, shoulder length, dark brown in color. I'm wearing a gray and black undershirt with a black blazer, and I have a virtual background with a letter A that stands for my name, and then a small little tree in the background. So welcome again, and thanks for being here with us today. Next slide, please. I'm going to provide very brief speaker introductions. First of all, I am introducing Dr. Lisa Mills, who has been a consultant in the field of disability for 31 years with a primary focus on state agencies and managed care organizations delivering employment and community-based services. She's also consulted on employment first, value and outcome-based purchasing across state systems, evidence-based models for advancing competitive integrated employment, and Medicaid home and community-based services. She has worked in 22 different states over the past 16 years under various contracts with state and federal government agencies, managed care organizations, and provider associations. Dr. Mills has been provided extensive experience in assisting state agencies to design new rate structures and reimbursement models which incentivize competitive integrated employment outcomes. She also works with states on the design and implementation of new programs for people with disabilities. Dr. Mills has also been a consultant for the Office of Disabilities Employment Policy since 2012. Our next speaker, Dr. Yasmina Barawi, has a particular interest in employment for persons with developmental disabilities. She has been a primary advocate for Employment First in Michigan since 2014, when the Michigan DD Network Partners launched a focused initiative on this movement. She was a state lead for the Employment First initiatives from 2015 to 2021, and she also worked to ensure that policies and practices were aimed at increasing competitive integrated employment for people with disabilities. Our next speaker is Chris Kubnick. He serves as the Chief Medical Experience Officer for Inclusa, Inc., the largest managed care organization in Wisconsin that supports the lives of elders and adults with intellectual or physical disabilities through the state of Wisconsin's Family Care Program. Mr. Kubnick has also held a variety of leadership roles in Wisconsin's long-term care system over the last 15 years. His experience as a multidisciplinary leader at Inclusa has provided him with a unique perspective on managed long-term care and has led to development of a nationally recognized innovations in the managed care industry. Our last speaker, Daniel Strutz, grew up in Africa. He used to dream about his future and never imagined that at 12 years old, he would come to live with his forever family in America. He is the youngest of 2 sisters and a brother in his family, but he is the tallest. He enjoys spending time running, playing the drums, playing with his dogs, and he also enjoys working. Although life has brought Daniel many changes and challenges, he is encouraged to share his story to inspire and to motivate others. Now, let's turn it over to the next slide, please. And our first presenter, Dr. Lisa Mills, take it away.
Thank you, Amy, and good afternoon, everyone. I'm happy to be here. I am a 54-year-old woman with a lot of short gray hair and sitting in my home with a background that's just a blank wall and a window and wearing a blue corduroy shirt. I want to talk to you today about advancing competitive integrated employment, particularly through managed care and where the opportunities are. Next slide. So I start all my presentations with the next 2 slides in terms of really focusing us in on the recognition we all have that we can and should be doing better with regard to competitive integrated employment for people with disabilities. Despite all the ups and downs that this country has been through, we continue to believe we should be doing better, and we have to find ways to do better in employment. Next slide. But interestingly, what I find is that still too many people hold the belief that we can't do better because we don't have enough money. And they can get really quite hung up on that without more money, we simply can't expect better outcomes. But what you're going to hear today is managed care systems and organizations that think about it differently and that say, we can do better if we can use our money more wisely. So they look at existing funds and figure out how to use it better. Next slide. So that the whole focus on how do we use our existing money more wisely has led to discussions among states and managed care organizations about not just about how much they are paying for services, but also how those payments are being made, more about the methodology for the payments as opposed to the amount of money being paid. And so quickly the discussion has moved from how much do we pay for service to wouldn't it be great if we could just pay for outcomes and quality, and rather than solely focusing on reimbursing for how much service is being delivered. And really that is the beginning of the conversations about value-based purchasing. I'm going to talk a little bit more about what value-based purchasing is before we hear from the other presenters. But over the past decade, I would say that there are many new models and approaches that have been developed that really focus on this idea of paying for outcomes and quality, and particularly around competitive integrated employment. What I've found is where those models have really worked and have been embraced, that has been because of good faith collaboration between the providers of services, the funders of services, and people with disabilities and their families themselves. Next slide. So what is value-based purchasing? Quite simply, it means that we tie part of the payment, or in some cases, all of the payment made to providers to the outcomes that they produce from the services they deliver. So it gives us an opportunity to reward providers for quality outcomes, regardless of the quantity of service they deliver. And in value-based purchasing, there's good, better, and best. Good models involve the funder paying more, but getting better quality and outcomes. And typically you would expect if you're paying more, don't you automatically get better quality and outcomes? Well, not always. So a value-based model that's working, where a funder is paying more, you can clearly see better quality and outcomes. A better model is to actually be able to pay the same amount of money and to get better quality and outcomes. And often that comes from giving providers flexibility in terms of how they deliver the services. The best model and the most ideal model is obviously that we pay less and we get better quality and outcomes. And sometimes that we've seen that happen with technology. We've seen that happen in the kind of acute and primary care side of managed care. We've seen opportunities where if we're smart about how we use our money, sometimes we can get better quality and outcomes without spending as much. But in general, I think all systems want to see better competitive integrated employment outcomes. They have other goals for community inclusion. And any goals like that, I would argue, require us to change the way we pay for services. Next slide. So what is managed long-term services and supports? Called MLTSS for short sometimes. Managed means essentially it's the use of managed care. And in managed care, states contract with managed care organizations, sometimes called MCOs for short. And the state no longer runs the long-term care system per se. They contract out the responsibility to managed care organizations. Those organizations are then the organizations that contract directly with service providers. And in long-term services and supports, there's two kinds of service providers. There's institutional service providers, nursing homes, intermediate care facilities, and then there are community-based service providers who deliver home and community-based services, including supported employment. So the states pay these MCOs using what's called a capitation, rather than simply paying them fee for service. The capitation is generally that every month, for every person they serve, they get a payment. And that is regardless of how much they may spend on that person's services. So the managed care organization takes all the payments for all the individuals they serve, puts them into a pot, and out of that, they have to make sure that they're adequately serving everyone, that they're meeting their needs and helping them achieve their outcomes. Regardless of whether some people, they might spend more than that monthly payment, and for other people, they might spend less. So managed care organizations have a built-in incentive and really a need to be able to serve people in the most cost-effective way. Next slide. So building on that idea, what has come to be very clear is that most MCOs still have been contracting with direct service providers using fee for service. So providers continue to get paid based on the volume of services they deliver. And it's been increasingly apparent that paying based on fee for service really has no tie to quality and outcomes. And even national provider organizations like ANCOR are recognizing that fee for service does not have a link to quality and value. And in 2019, they published a report looking at advancing value and quality for people with intellectual disabilities. And they said moving toward paying for value offers the potential to increase efficiency, quality, and flexibility in service provision. So the provider community is beginning to recognize that there are advantages to being paid differently. Next slide. So MCOs clearly want to contract with direct service providers using something other than fee for service. They want to be able to buy services in the most efficient manner. Providers are also seeing the benefits of being paid by something other than fee for service. And in particularly with the direct service workforce shortage, the idea of being paid for the volume of services delivered is really not workable anymore because they simply are struggling to find enough staff to do the work. And that direct service workforce crisis is not going away. Even after COVID is expected to be with us on a very long-term basis. So being paid for outcomes of the services that you provide gives providers the flexibility to provide the service in the most efficient and cost-effective way. So they can serve more people with a limited direct service workforce they have. Unfortunately, our history has been face-to-face service delivery, which is the most expensive and most labor-intensive way to provide services to people. So if we want to really serve people in the community in an individualized way and avoid congregation and segregation, we have to move away from face-to-face fee-for-service payment structures. Next slide. There are a lot of opportunities that have come through managed long-term services and supports about how we can move away from this face-to-face volume-driven service delivery. First, we can focus on one of the key goals of Hcbs, of home and community-based services, which is to assist people to be as independent as possible. And we are learning that there are a variety of strategies that can help us do that if our payment structure isn't driven by face-to-face service requirements. So we can use technology and adaptive devices to increase independence. We can use teaching strategies, which has been a long-standing approach in supported employment. And as we begin to move away from doing for people to doing with them, and then ultimately to teaching for independence, we can recognize how much performance-based or a value-based payment structure can help us do these things and enable people to be more independent, as well as using natural and community supports that are available in integrated places. Next slide. So the drive towards paying differently has really come first in supported employment. And I think it's very obvious that what the reasons are for that. Fee-for-service does not reward supported employment providers for using what we recognize as best practice. Those are things like fading of the job coach, assisting people to work as many hours as they can, and preventing job loss. Fee-for-service doesn't incentivize any of those practices. What it does is inadvertently rewards poor practices in terms of a provider who fails to fade, a provider who focuses more on how many hours of job coaching are they providing versus how many hours is the person working. And in a fee-for-service model, if someone loses a job, it often results in another authorization for more services. Next slide. So you'll see this slide twice in the presentation. It's hugely important in terms of what happens when a supported employment provider is really good at what they do, when they use best practices in everything they do. The more capable organizations actually need less hours to deliver the service, less hours to find people jobs, less hours to coach them to independence, less hours to engage natural supports. The result is they can bill less hours and we pay them less as a result of being a more capable and stronger organization. That's what we have to turn on its head if we want more competitive integrated employment outcomes. In fee-for-service, unfortunately, what we see is providers who do really great work earn no more than providers who don't do that well. And in fact, the providers doing the best work often earn less. Next slide. Some examples of value-based purchasing that I wanted to share with you before you hear from the presenters from Michigan and Wisconsin. There's a lot of things that have started to develop around competitive integrated employment. Paying for pre-employment services like career exploration, discovery, a job or career plan, paying for those on an outcome basis rather than fee for service. Also paying for job development and placement on an outcome basis to encourage getting to that outcome because we know people want to go to work. Paying for job coaching based on the hours the supported employee works rather than hours of coaching. And in some cases where states have said, let's take a step away from pure fee for service before we go to a pure outcome model, we've seen a tiered fee for service rate structure that incentivizes fading. Next slide. A couple other examples. Some places we're seeing bonus or quality payments on top of fee for service for quality outcomes, like people earning higher wages or working higher hours. And then one of the things I think is most promising is the use of pay for performance with direct service providers. States use this with managed care organizations, but there's an opportunity to use it with direct service providers, which means if they meet a certain milestone in a contract year, they would receive a payment. Things like expanding the total number of people they have in competitive integrated employment, or having a high referral acceptance rate, having their staff get certified in supported employment, ending employer of record arrangements so that individuals working are directly employed by the businesses where they work, increasing the number of employers a support employment provider partners with, or obtaining a support employment services contract with a state VR agency. Next slide. My last slide, one of my favorite cartoons. Sometimes really good ideas don't happen purely because people say they don't have time. I think AOD grantees can be incredible advocates to get both funders and providers focused on fixing what's not working and looking at the ideas that are out there that do work to create more fair funding structures that benefit both provider and funder equally, creates a win-win situation to move competitive integrated employment forward for people with disabilities. So thank you. I want to pass it along to Dr. Yasmina Barawi from the Michigan Developmental Disabilities Council.
Hello, good afternoon, everyone. My name is Yasmina Barawi, and I serve as a subject matter expert both with DETAC, and I'm the Deputy Director at the Michigan DD Council. I'm an Arab American woman with salt and pepper, curly short hair, and today I'm wearing cat eye glasses, a gold necklace, and a black, gray, and gold tiger patterned shirt. I have a simple blurred virtual background. So I'm here to tell you a bit about the Michigan DD Council's work with value-based purchasing. We began our Employment First advocacy in 2013 by adopting a position paper on Employment First, followed by an advocacy report in 2014. In January 2015, the Michigan DD Council applied for and received a technical assistance initiative, which served as the underlining framework which supported Employment First in Michigan through the Office of Disability Employment Policy. And at the time, they had something called the Employment First State Leadership Mentoring Program. This initiative provided the technical assistance that's guided the majority of the work conducted in the state related to value-based purchasing for employment services from 2015 to 2020. In 2015, the state of Michigan established an Employment First executive order. And in 2017, the DD Council advocated for concrete steps to support the executive order. It appeared that it was there on a piece of paper, but there hadn't really been much that the state had done to support what was in the executive order. So working with the provider organization and the statewide Independent Living Council, an implementation plan was developed. And in fiscal year 18, the state of Michigan allocated funds to support objectives stated in the executive order. As part of the allocated funds, the DD Council was contracted with consultants to provide technical assistance in a number of areas to further the employment first priority. One of the areas that they funded was an initiative to co-create innovative contract and purchasing strategies to achieve competitive integrated employment outcomes as part of our employment first rate restructuring focus. Next slide. So Michigan created a large stakeholder group, which included many state departments and programs, which agreed on a vision and mission of employment first for Michigan. The vision statement for Employment First was that all persons with disabilities in Michigan would realize their fullest employment potential through the achievement of individual, competitive, integrated employment outcomes. The mission statement stated that the purpose of Employment First was to maximize the opportunities for persons with disabilities to achieve independence and economic self-sufficiency, promoting individual, competitive, integrated employment through a collaborative and seamless model. So we had a lot of partners valuing employment that gathered around that mission and vision. Within the outlined Employment First implementation plan that was developed was a dedicated focus on rate restructuring. And the goals of that initiative are outlined in this slide, which were to increase the number of working age members 16 to 64 that worked in competitive integrated employment, supporting community mental health service providers to use alternative payment methodologies that would reward and incentivize the use of best practices in supported employment, developing solutions for addressing negative impact on the use of best practices that often resulted in providers being able to bill only for face-to-face delivery service, and then matching outcomes desired with payment models to encourage maximum return on the investment for funders. Next slide. So just to give you a little bit of the Michigan context, Michigan uses a 1915 BC combination authority to implement its Medicaid long-term services and supports program. The state is organized into regional prepaid inpatient health plans. There are 10 that contract with local government community mental health programs to provide case management services and contract in turn with direct support providers to provide services. However, our Medicaid agency does not currently establish statewide rates for employment and other Hcbs services provided through its waivers. The DD Council, in partnership with the Community Mental Health Association and the statewide provider organization, came together and issued a request for proposals for CMHs to apply for technical assistance in this transformation. The technical assistance included support for the CMH in provider contracting strategies and principles and outcome-based funding options, as well as transformation support for employment service providers within that respective catchment area. So the slide highlights that focus on working with the community mental health programs on revising their contracting and purchasing methodologies, and then working with the community mental health organizations to revise their person-centered assessment and planning processes, and then working with the providers on the ground to transition from their facility-based services to their community employment-based services. Next slide. So between 2016 and 2019, 12 CMHs were engaged in these efforts. 6 of the 12 implemented an outcome-based model reimbursing for hours worked. 3 of the 12 implemented incentive payments or milestone payments to move towards more competitive integrated employment, but did not move to implement payment for hours worked. 2 began implementation but didn't implement due to COVID. And then 1 started purchasing Discovery but continued to reimburse on a fee-for-service model due to system challenges with claims. And then there are 2 that we're currently starting to work with for 2020, 2021, and 2022. The state Medicaid agency did not seek CMS approval for changes to their 1915 C waiver to facilitate CMHs in implementing the outcome-based payment models for supported employment services developed through the initiative. Next slide. Support for these transformation efforts have come from 3 funding sources. First, the Office of Disability Employment Policy Technical Assistance that we received from 2015 to 2020. It was an average of 300 hours of technical assistance per year. Second, the state appropriation that we received for fiscal year 18 and 19, that was $500,000 per year for a variety of employment first activities, including this rate restructuring technical assistance, and also for provider transformation technical assistance. And then finally, the DD Council has provided limited funding in fiscal year 21 and 22 to continue the momentum. Next slide. The DD Council has been the lead organization on these efforts. This is an atypical role for the council to play, but one that was necessary in our state where the DD system had expressed a lack of capacity to lead the initiative when it started in 2015 with the ODEP funding opportunity. So at that time, the DD Council secured the technical assistance, and then in partnership with the Community Mental Health Association and the Statewide Provider Association, now called Encompass, went on to issue requests for proposals for the community mental health agencies to apply for technical assistance in this transformation. The technical assistance included both support for the community mental health agencies in their contracting for outcome-based funding options, as well as transformation support for the employment service providers within that community mental health catchment area. So they really needed to work in parallel to get momentum for the changes in any specific area. Next slide. In Michigan, during this transition, the DD Council continued to provide a variety of trainings for community mental health case managers, as well as supported employment providers. They provided Association of Certified Rehab Educators certification trainings in collaboration with the provider organization. We provided family and guardian trainings focused on the benefits of supported employment. We provided work incentives trainings that supplemented a number of existing trainings that we already had in the state. And we started a school to work pilot initiative, as well as hosted the state's first annual Employment First conference. The conference offered a place for collaboration, learning, and development of relationships between state of Michigan employees, supported employment providers, and other IDD provider organizations, CMH employees, voc rehab employees, school districts, individuals with disabilities, and families and guardians. Next slide. In Michigan, the Employment First policy collaborative efforts launched an unexpected partnership between the Michigan DD Council and the Statewide Employment Provider Association, which is now known as Encompass. This partnership was unexpected due to perceived differences in CIE philosophy, competitive integrated employment. We still have some differences in our philosophies, but as a result of our partnership, there was a joint voice to funders and employment providers to achieve the vision of increased competitive integrated employment. And when we were actually doing advocacy and we're meeting with the Lieutenant Governor trying to get funding to support the executive order, the Lieutenant Governor actually said to us, when you two agree, it makes it easy for me to support this initiative. Because typically the various organizations would be with their lobbyists or their advocacy coming with opposing views, and that would make a joint solution more difficult. Next slide. So in terms of lessons learned, in Michigan, the DD Council and the Provider Association had not worked on any joint initiatives prior to 2015 based on our difference in philosophies. Once we both stepped out of our comfort zones, a lot of progress was achieved. And both groups received a lot of flack for working together, but by stepping out of our comfort zones, a lot was accomplished. There's still more work to do with the provider organization, with individual providers, and with the state system to make competitive integrated employment a reality for all persons receiving services in Michigan. Next slide. So the current focus is on maintaining the momentum moving forward for providers that have received technical assistance. It's also to maintain the stability of the transformation process through the maintenance of in-state mentors that can continue to assist with provider transformation mentoring. It's also to continue to expand the number of community mental health organizations that are receiving rate restructuring technical assistance. And finally, to continue to work on systems change. I'd now like to turn it over to Chris Kubnick, the Chief Member Experience Officer at Inclusa.
Thank you. Good afternoon, everybody. My name is, next slide, please. Good afternoon, everybody. My name is Chris Kubnick. I am the Chief Member Experience Officer with Inclusa. I'm a Caucasian male in my mid-40s with brown short hair. I'm wearing a blue sports jacket today with a light blue shirt, and my virtual background is an Inclusa logo behind me. I'm really glad to be here today to speak about Inclusa and the work that we've done in partnership with our provider partners in developing and implementing a value-based purchasing model for supported employment services. Just really quickly, just some background on Inclusa. We aspire every day to empower people to explore and achieve life's possibilities. And our mission is to, in order to maximize health outcomes, we proactively partner with others to build vibrant and inclusive communities that offer people dignity, choice, and connections. We really see our role as a managed care organization, really more around asset-based community development and engagement in our communities as our key foundation for what we do. Next slide, please. So in 2000, Inclusa started operating at the inception of the family care program. So we started small and grew, and I'll talk about that growth as we talk about expansion of our value-based purchasing model. We are a 501c3 designated organization. We are the largest managed care organization in the state of Wisconsin. We currently support almost 15,900 members on a day-to-day basis. About 50% of the individuals enrolled in Inclusa are adults with intellectual disabilities. About 33% are older adults, and about 17% are adults with physical disabilities. We currently operate in 68 of 72 counties, and I'll touch base on where we're actually located and where we're not located on the next slide. And we currently have just right around 1,150 colleagues across the organization. A majority of those individuals are either registered nurses or social workers. We contract with over 6,000 service providers providing almost 40 services across the family care benefit. Next slide. So this slide right here provides you a visual of the state of Wisconsin. All of the counties that are teal are the counties in which we as an organization operate in. There are 4 counties that are white, so you'll see right down in the southern center part, that's Dane County, so that's where Madison, where the capital of Wisconsin is. And then you see Milwaukee in the southeastern part of the state, Milwaukee, Racine, and Kenosha. Those are the 4 counties that we are currently operating in. I think one of the things to highlight here is those are the most urban and metropolitan areas in the state of Wisconsin. Inclusa finds herself in what I like to say either the rural area of Wisconsin or the really rural area of Wisconsin. So we tend to provide supports to the most rural parts of the state, and feel like we've been able to really be successful in supporting those areas, and really being connected to communities is why we've been able to do that. Next slide. So as Dr. Mills pointed out, you saw this slide earlier and you see it again. And the real reason is because back in about 2010, we found ourselves as an organization in this exact need for paradigm shift. So at that point in time, we were delivering family care in 4 counties, excuse me, in north central Wisconsin. We had about 2,000 members at that time, and we're supporting, really had about 9 employment providers that were providing support. And what we were finding is as our teams, we always had a really strong focus on employment, even at that point in time as an organization, and saw significant value in really looking at how do we continue to advance employment outcomes for individuals that were enrolled with our organization. As we started to engage providers and specifically our teams as they were working around person-centered planning and advancing employment opportunities for individuals, we did find ourselves in this place where we had providers and essentially we're asking them to fade and continue to fade. And the way we were continuing fee for service, essentially asking them to continue to decrease your revenue. And the only way that we can hope that you continue to get additional revenue and support for the great work that you're doing is that you'll get more referrals because you're a higher quality provider. And we had a handful of providers that were really successful, but really struggling. And we had a handful of providers that, other providers that were really struggling, but were being financially successful and finding really good job matches. And when I talk about fading, it's really about as we engage employment providers and they're focused on finding the really good job matches for individuals to their strengths, really those natural supports at work that we all receive, really asking that provider to back off on the amount of one-on-one time that they're providing specifically with members, or with those individuals that are receiving that support. So I'm really asking them to really look at how they're working, and the fee for service support, it just was not supportive. So we knew we had to do something different. And we had an opportunity because we had some Medicaid infrastructure grant funding that was finding their way into the state of Wisconsin, which we were able to leverage. We also had some really supportive providers that wanted to come to the table. Next slide. So I really wanted to start with talking about how did we approach developing the value-based purchasing model. And I'll touch base on the model and what we've seen as outcomes. But on the forefront, the model is effective, and we found it to be effective, but really the process we've took was what allowed it to not only kind of move forward and individuals experience the employment outcomes that they are and have our providers be successful. We recognized we needed providers at the table early in the process. So we brought providers in as we developed the model, and they co-created it with us. So we really engaged providers strongly on the front end to develop the model. And that was the first step of engaging providers. But we have gone and since evaluated the model. So it's really been in operation since 2012. And we've expanded it across our current service region over those 9+ years. And throughout every step of the way, we've engaged providers and had them at the table to both help us reevaluate and then define a path forward. As was spoken earlier, which is happening in Michigan, we really needed to invest in technical assistance. We recognized that we could not just ask our providers to meet outcomes without us providing some key some key areas around technical assistance and investing directly in our providers. So we did that in a handful of ways. First, we really provided ongoing and broad technical assistance to a group of all of our vocational providers. We continue to do that today. We created opportunities for providers to start to create some peer-to-peer groups and break down some of the competition and find ways that they could collectively work together, learn from each other, and grow collectively together. And we were really trying to be the conveners of that type of peer-to-peer technical assistance. We also brought in technical assistance specifically for individual providers as they need that, and as they needed that both to change the way they're supporting individuals, to continue to move their delivery in a different manner, while at the same time, some of the information and thinking about business and delivering supports needed to change as we started to shift towards outcome-based. We also really focused on risk sharing on the start of the development to present. So when we developed the model and as we've rolled it out, we always created an 18 to 24 month transition for providers. So they're able to see what fee for service looks like in their revenue at the same time what value-based purchasing is. And as they look to modify approach and start to meet more outcomes, they could easily see their revenue change and how they're able to evaluate and support the financial and reimbursement strategies changing also. So it didn't create a cliff for them to drop off of. They were able to really position themselves to be successful once we made this switch. We've also built some outlier processes, and they're very minimum use of outliers. So for providers, for situations in which the situation just doesn't necessarily fit the reimbursement model, we're able to support that. And we brought in external experts to help to build that. So it wasn't a managed care organization building an outlier model. It was really bringing in external expertise. And then lastly, on the risk sharing piece, we currently have really within the model, the ability for catches. So if providers are truly seeing loss in funding or loss in their business, it really identifies in red flags that we need to reevaluate what that current rate is to make sure it's up. And then on the same side, if providers are seeing significant gains, it allows us to reevaluate the rate. Next slide. So this is the model in which we were, as we worked with providers, we were able to develop. So our reimbursement model pays for hours worked by the individual versus the hours of supported employment support provided. So it really incentivizes multiple best practices, including that fading, use of systematic instruction, natural supports, technology, and helping people maximize the hours worked and preventing job loss. So really want to maintain that work while increasing the amount of hours that individuals work were the goals we seek. So as you look at this table, we recognize as we engage providers that there are two kind of drivers to the level of support that they were providing to individuals. The first is new job placements tended to have higher level of job coaching. And as that individual was employed across in the same employment environment, same job, those percentages of support decrease. So you can see across this, we fund the hours worked. That percentage that we fund per rate decreases as individuals are longer on the job. We also recognize that individuals have different support needs. So as individuals have either higher acuity needs or lower acuity level needs, we play a higher percentage of that negotiated rate or a lower percentage. So across the table, you can see longer time in a job, less percentage, higher level of support, acuity needs to lesser acuity needs, those percentages decrease. Those percentages were not just plucked out of the air either. It was part of really engaged process with providers and them reporting what they're experiencing. And so providers the percentage was really based on real-time experiences for our providers. Next slide, please. And over time, we recognized we needed to, again, modify what we were paying providers and create some consistency where we needed to be. So as we've grown and expanded this, we've been able to then continue to look at the contracted rate in which we base our coaching costs off of, based on the quality of outcomes and being able to recruit really high quality supported employment job coaches. So right now we're really looking, we tend to provide at $32 an hour, and that's verified by provider cost reporting. And again, the acuity tier on the left really allows us to increase from a challenge and creates equitability across competitive integrated employment. So this is the same table you just saw, but putting in the actual dollars that we pay per hours worked. So you can see for an individual that may fall in the acuity tier 1, their first year on the job, we pay that provider $30.40 for every hour that an individual works. Next slide. So what did we experience? What was the impact? So as I said, we first developed this model started in mid-year 2010. It took us to about 2012 to actually develop it and allow providers to experience it before we actually made the full switch in those 4 counties in North Central Wisconsin. So from a 9-year impact, when you look back to 2012 on implementation to the end of year 9, the first year we saw 35% growth in the number of people working in competitive integrated employment in those 4 counties. In those 4 counties on year 6, we saw a growth of 70 and almost 70.5% growth in CIE. And then the 9-year mark, we were at 92.2% growth of percentage of individuals working in CIE in that 4 county. In 2013 into 2014, we expanded from those 4 counties into 11 counties in the northwest part of the state. At that time, there was a previous managed care organization there that was providing the program. They left, we were awarded that part of the state. We came in and had to develop our network, and essentially we're providing support to about 2,500 new members on January 1st of 2014. And we worked with those providers in the Northwest. And that's pretty much one of the most rural part of the state of Wisconsin. In 2 years of post-implementation there, we saw 31.5% growth in the number of individuals that were employed in competitive integrated employment. And just as importantly, we saw significant growth in the number of hours those individuals were working. So we saw 105% growth in hours, total hours worked by members working in CIE, and a 56% increase in the average hours worked per month for members in competitive integrated employment. Just as a side note, we just kind of finalized our 2021 numbers going into 2022. We saw across all 68 counties, we saw a growth of 5% for adults with intellectual disabilities ages 18 to 64. So significant growth, recognizing the pandemic is still where it is, but we saw really a lot of growth in 2021 and 2022. We're currently at, for that same age, for adults with intellectual disabilities, 18 to 64, we're at 20% in competitive integrated employment. And again, those are in the most extreme rural counties, not in the Madison-Milwaukee area. So really happy with that growth. We have a lot more way to go, but really happy with that. Some additional outcomes that we're seeing, if you can go to the next slide. Thank you. So that's one of the questions is, is it cost effective, and are you seeing high quality? And one of the ways in which we can, identify how cost effective it is, and there's broad holistic ways we can look at that. We have invested in employment outcomes and have invested in providers and the cost. But we wanted to compare it to other services if an individual was not spending their time employed and working, and if there needed to be other supports in place. So as we look at pre-vocational services compared to what we're actually paying per hour an individual worked, it's pretty significant. So on average in 2013, we were experiencing about $9.93 payment per hour worked, and recognizing that cost across the metric kind of goes down. We saw that go down in 2016 to $9.70, and the end of 2018, we were up to 975, but really high quality, cost effective authorizations for our teams when they're seeing the cost of individuals working per hour. When we compared it to pre-vocational services in 2013, we were seeing it being about 28% less than what we were paying on average for pre-vocational service hours. And then in 16 and 2018, we saw it was still proving to be extremely cost effective at 20% less than what we would be paying if we're for pre-vocational services for individuals. So as Dr. Mills spoke to, as a managed care organization, really focused on not only quality, but cost effectiveness. And this model is showing that we're able to do both, be cost effective and deliver really high quality outcomes for individuals that are looking for employment opportunities in their life. So that is the end of my slides. I'm gonna transition to Daniel Strutz, and Daniel can speak to his journey to employment.
Start the video.
Thank you for joining us today, Daniel.
You're welcome.
I am going to be asking you the questions. So next slide, please. Please introduce yourself. What is your name and where are you from?
Hello, everybody. My name is Daniel. I'm from West Africa, Burkina Faso. I'm sitting at the office. I got a lake behind me, a picture. So I'm 6'3". I got a black hair. I wearing a purple shirt and a purple tie. I'm a very interesting out there. It was wonderful. Listen to all those speeches. It was really great. I loved it. It was first. I did some work. Did some Inclusa. They were very helpful. They are wonderful. So they were incredible. They helped me everything up there. They get the first. They did a lot of things out there for me. I don't know how I can thank them that. They're really amazing.
That's great. And can you tell us a little bit more, Daniel, about how you figured out what you wanted to do for a job?
How did I figure out? I did some little bit. I did field a little bit training. This little bit. First, I did training with Catherine. I have Catherine sitting here. She the one that helped me get to stuff like she went training with me a little bit, how you act on jobs and how you you talk to your boss, you got to look at her eyes, you got it wasn't COVID, you can shake the boss hand, but on COVID you can't shake hands. I'm really sorry for all of that. I wish it's something that we can do in the world, but the world's got the worst COVID. I'm sorry about that.
Thank you for sharing that, Daniel. So you were able to explore options through getting some training and trying different things, different tasks, different jobs.
Right.
How did that look like for you? So I see Catherine is with you, and Catherine was able to provide some support to help you explore and learn about jobs. Is there anything else you want to share about that?
She's a great Majan training person. Looking for a job. If you're looking for a job, go to her. She's the amazing one. She's the amazing one. She will help you, and she's got more care to you, help you how to find the right job you're looking for.
We did. We had quite a bit of work to do ahead of time, like all the other panelists were talking about. And with the support of Inclusa, we were able to do the pre-employment work. And not only because of his life history, we had some things to overcome, but also he had some not so good experiences with job coaches. And so we had a little bit of work to do behind the scenes.
Correct. That's really incorrect. First, I work at Triggs, if you know what that is. That's my very first job. I worked there. I had a job coach. It wasn't how to, job coaches got to be nice and patient, because the one I had wasn't good. She wasn't very patient with me much. Like I'm doing something, she's told me that's not right, how to do it. But please, like if you have a job coach out there, if you're looking for the coach you, you had to just give them time. Just give them time. Maybe they're nervous or something else.
Want to do a good job.
They got learn. They got do good.
So we spent a lot of time going over what good coaching looks like, what a good fit in employment looks like, all of those things, so that when we were ready, when he felt he was ready, it was a very easy flow to know that this was a good fit for him.
Correct.
And one of the things that the other panelists had said, and I just want to touch on that for 1 minute, was he was very afraid of overcoaching.
Yes.
So it was bad coaching and it was overcoaching.
Yes.
And so, yeah, he's the poster child for that. And so I had to convince him that I was not going to stay with him. I was going to get him up, get him going, and that was it. I was out of there. And so there was a little bit of behind the scenes.
Yes, it was really, I think for her helped me. Like she's the one let me trust, like to the new coaches and stuff like that, because that was very hard for me to trust, because I had one job coach wasn't good with me, and she's the really helped me get my fear to the new coach.
That's just great. So not only did you explore career options, but you were able to get support, to go through the person-centered planning process to make sure that you did have a good job match. Next slide, please. We have a few more questions for you, Daniel.
All right.
So we talked a little bit about how your providers supported you to explore your jobs, how your providers supported you to explore options and get a strong match for a good support and a job coach. Can we learn a little bit more, Daniel, about your job? Where do you work and what do you do?
I work at Goodwill. My job is I do dog greeter, take donation. Customer come, they drop their stuff off, and I take them from them, and I go inside and show them through, and then see what stuff we need and what stuff we don't, like some stuff we don't want it.
That's very important to sort through some of the donations to be sure that you're selecting what you know is able to get processed and resold. Now, Daniel, could you tell us what is the favorite thing, your favorite thing to do at work? What's your favorite task?
Well, my favorite task is being in the back.
Oh.
It's really amazing. I love going outside. That's my very favorite. I like to be outside a lot, taking donations from them, because I love going outside a lot.
Oh, that's just wonderful.
Yeah.
And Daniel, what advice would you have for people with disabilities that are looking for a job or that want to get a job? Do you have any tips for them?
Well, if people have disability like me, so it just I'm sorry, my English not good enough yet, but it's good now.
One of the things that we've talked about was having confidence in yourself. When other people maybe put you down,
yes,
you have to rise up. I mean, you had a lot going on in your whole life.
I did.
And then you had to graduate from high school, and then you wanted a job, and then, I mean, it's a lot. It's
was
really a lot. And so you always had all of this inside of you.
Yes, I did.
You just had to find out what good supports look like, and the
Correct.
job that you love. You love being outside, absolutely right.
That's right.
And being around the customers.
That's right.
Love that.
I love being there.
And it gave you a lot of confidence as a man, don't you think?
Yeah, that's it is. It's love being like, it's really amazing. It's like, it's lovely.
Oh, that's just wonderful. Before we move on, Daniel, to show us some slides, some photos of you, is there anything else that you'd like to share about your job or your journey to employment?
My journey is continue working there as far as I can. It's a lovely place to work.
Oh, that's just great. So I am going to ask for the next slide, please, so that we can show some of the photos that you shared with us. This is Daniel at 12 years old with his mom and dad. Next slide, please. And here's Daniel with his siblings and the rest of his family, huh, Daniel?
That's right.
Was this during Christmas?
No, well, yes.
Very cool. Okay. And then the next slide is you at high school graduation.
Yes.
Very awesome. And then the next slide. Hey, that's you at work. You got the job. Congratulations.
Yeah.
Next slide, please. And what you doing there?
I'm going through stuff in the cart.
Awesome. Next slide, please. Hey, you're presenting here with Catherine, aren't you?
That's right.
At the Self-Determination Conference. What a great opportunity to have you there.
Thank you.
Next slide. And there's Daniel in the winter. Thank you so much, Daniel, for sharing your journey with us today. Now we will transition over into the question and answer portion of the webinar. We have quite a bit of questions in the chat box, and so we will start reading them and assigning them to speakers. This one is very long, but it's important. And this is for Lisa, Dr. Mills. I can see how restructuring from fee for service to a focus on outcomes might discourage providers from working with individuals with more challenging behaviors or significant intellectual disabilities. Have you witnessed this, and or are you concerned about this, given that the individuals having greatest difficulty reaching independence and integrated employment are the ones that need services the most?
So that's a great question, and it's often a question I get. And so I think it's important in any outcome-based or performance-based funding model to make sure you take account of people's level of challenge. And so that's why when you saw Inclusa's model and the models we're using in Michigan, they do have levels based on people's level of, you can use whatever word you want, level of challenge, level of acuity, level of disability. And so the expectations for providers are different. The payments for the outcomes are higher when they serve people with higher support needs. And that is really important in avoiding the thing we have always called as creaming. If I have seen these kind of payment models where it's just a flat payment, and when you have flat payments, then there's a disincentive for a provider to serve people with higher needs where they're unsure if that flat payment will cover their costs. So I only ever promote models that take account of people's level of disability.
Thank you for answering that, Dr. Mills. We have a next question about follow-along services that will also be assigned to you, Dr. Mills. This question says, here in Texas, vocational rehabilitation helps get the jobs, but if the person does not have waiver services, there is no follow-along if a person needs further support. How did you make it work through the various agency funding streams? That sounds like a Yasmina question too, along with acute health care for all, because MCOs only provide LTSS for kids and adults with extensive medical needs.
So I read that question, and I think the CMH that you described that does provide adult long-term services and supports would be the organization that could pick up after VR. But we are certainly not suggesting that this solves waiting lists. This can contribute to reducing waiting lists if we can more effectively serve people, and therefore when they reach full independence or as much independence as they can reach, especially through competitive integrated employment, that we actually spend less in the long run providing their supports and then are able to serve more people off the waiting list. So these models have all been developed in places where long-term services and support funding is available to people.
Okay, thank you for that, Dr. Mills. We have some questions.
Can I also answer that, Amy?
Oh, yes, please do. I was
Okay.
about to say, I have the same question for you, so go ahead.
Okay, so I
Dr.
just want to
Barawi.
say in Michigan, as part of our employment first work, the Behavioral Health and DD Administration Services, which is our DD agency, and our Michigan Rehab Services agencies entered into an agreement to facilitate competitive integrated employment. And the agreement really serves to facilitate the coordination of supported employment services, including those extended services, and addresses how collaboration with the state Medicaid program will promote competitive integrated employment. And so there was really some leadership at the state level to map out how that was supposed to work. And then at the local level to give some guidance. And so I just wanted to share that I think most agencies should have an agreement like that in place, but if they don't, they might want to visit that.
Thank you, Dr. Barawi. We have some questions for Chris as well, but what I want to do is answer a question that we got and a comment from Cheryl. Does Daniel actually earn minimum wage? Goodwill often pays sub-minimum wage, and that's not CIE. Well, I agree, and we at the DETAC also agree that there are Goodwills that do provide sheltered work and segregated services, but we at the DETAC worked to ensure that we knew that Daniel had gone through the person-centered process. We worked to ensure that Daniel was getting paid at least minimum wage. We worked to learn more and take a deeper dive into Daniel's life and how he received supports and services. So he is earning minimum wage, and I'd like to clarify that he does not work at a sheltered workshop. Next question. Chris, this is for you. How did you address concerns regarding benefits for individuals and families when encouraging providers to maximize hours worked?
Yeah, great question, and definitely one in which we've taken kind of a multiple tiered approach. I think our care teams recognize as an organization that we have a focus on employment. So you know, when they're working through person-centered planning processes and engaging in that approach, you know, and having conversations around employment outcomes, you know, they're able to recognize that can be a tension and a concern for guardians, and try to understand what their concerns and questions are. We do have internal resources. We have an employment and community integration focused team that are able to help support our care teams when they're engaging individuals and through person-centered planning. And then we also have within the family care benefit package, within the supported employment definition, work incentive benefits and analysis is part of the service that we authorize. So we have great provider access, and our providers are extremely knowledgeable and able to support individuals as they explore employment and employment outcomes to be able to understand what that impact may be on their benefits, and start to decrease that level of concern when they see actually the opportunities that they have in front of them to earn more income and be better connected to their communities.
Thank you, Chris. We have a couple more for you, so I'm just going to shoot. This is from Alan Bergman. Hey, Alan, thanks for joining us. Are you tracking earned income, benefits, taxes paid, reduced SSI, and Medicaid costs? Those numbers can be very compelling.
Yeah, so we are tracking wage, so we do understand what average wage is, and looking at that across individuals. As far as benefits and taxes paid, that's not something that we're currently tracking, but something we can probably take a better look at. Overall Medicaid costs, so there are things that we do organizationally when we look at some cost to acuity ratio, because we are a Medicaid or managed care organization. Our capitation payment, as Dr. Mills talked about, is really spread, and we try to evaluate individual acuity and the cost of their plan just to better understand where we're at. And we are seeing overall reduction in the cost to acuity ratio for individuals that are employed. So comparative to support needs and that, we are seeing an overall kind of reduction when it comes to Medicaid costs related to individuals that are employed in the community.
Excellent, Chris. And just one more for you. Oh, Lisa is typing the answer. So Phil, Dr. Mills is typing the answer to your question. How does a Wisconsin model 25+ month rates compare to other day or pre-vocational rates paid in the state?
I'll just go ahead and answer that because that is something we have tracked from the beginning at Inclusa, and it's been consistently roughly 20% less. The average cost per hour worked for Inclusa under that model is roughly 20% less than the average cost for an hour of day services or pre-vocational services.
Excellent. We have just a few more minutes for the question and answer period. I want to add, thank you, Daniel, for providing some clarification about the wage that you receive in your job. I just want to read what Daniel placed in the chat box, what he typed. It says, initially being hired, my wage was minimum wage, but after completing training, I was given a raise of several dollars per hour. And Daniel is just letting everybody know that they offer good competitive wages. So just to clarify and just to, Daniel is getting paid over minimum wage, and he is in a competitive integrated job. Couple questions that we'll have before we transition over to center updates. Yasmina, as a grantee from the DD Council, what advice would you have to other councils across the country that are trying to move the needle on employment through managed long-term services and supports? What initial steps can a council take to help move this type of effort in their state?
So I think the biggest advice I would give is to work with non-traditional partners. So in Michigan, we had done a lot of advocacy for a long time, but kind of had a line in the sand that we wouldn't work with the provider organizations that were doing facility-based work because they weren't compatible with our model. And I think that I understand that, but at the same time, the new director of the provider organization in 2015, told me we need help to transform, right? And so how can you help us to transform? We know we need to go in a different direction. So I think that would be advice that I would give. I would also give the advice to work with a lot of different stakeholders. So we work with our DD agency. We worked with our CILs closely. We work with the providers closely, and we work with our funders or the funders of DD services. So it has to be a broad approach.
Thank you so much, Dr. Mills, Dr. Barawi, Chris, and Daniel. We will now move to provide center updates. So thank you for answering the questions. And just as a reminder, Dr. Mills, Dr. Barawi, and Chris will be participating on our Friday office hours from 12 to 1:30 Eastern Time. This office hour session will now be hosted via Zoom. So if you need accommodations, please send us an email to let us know so we can secure those accommodations for you. Next slide, please. Please join us on March the 8th for our upcoming webinar where we will feature Mentra, a hiring platform for neurodiverse talent. Mentra will share their journey and how they work with employers to help individuals with disabilities obtain meaningful, competitive, integrated employment. Next slide, please. And we are so thrilled to announce our new Results in Systems Excellence e-learning community cohort. The topic is focused on assistive technology in employment, and it is open to all grantees. Co-facilitators are Jennifer White from Able Opportunities and the AT3 Center. This specific cohort is going to be facilitated from February 24th to May 5th, and it encompasses basic introductory sessions to assistive technology, identification of partners, of resources, and how to support people with disabilities to acquire and to learn how to use assistive technology when placed in competitive integrated employment. So if you are a grantee and you are interested in learning more or registering about this free technical assistance opportunity, please click on that link and register. Next slide, please. We are also absolutely delighted to share that our learning management system platform is final. We have been working to ensure that the platform is user-friendly, and I am just extremely excited and delighted to share that our first class will be finalized at the end of the month, and that is going to focus on building an employment program in your SIL. The second course that we have is going to focus on complementing the assistive technology and employment e-learning community. So what we will be doing is we'll be sending blast email announcements out to each grantee. So my suggestion is to keep on the lookout, particularly Centers for Independent Living, because that is the first class that we have. So we will be sending each Center for Independent Living username and some credentials to access that class and register for it on our learning management system. Next slide. So before we dive into sharing our web pages with you, we have a special announcement to share, and that announcement is that the Disability Employment Technical Assistance Center is excited to welcome our new senior advisor, Annette Shea, who is on the webinar with us today. Annette, would you like to briefly introduce yourself really quickly to our audience?
Sure. Thank you, Amy. And yes, this has been a wonderful webinar. This topic is of interest to many folks. And it was really exciting to hear all the presentations. And some of you may remember me from the time when I worked in the state of Massachusetts before joining CMS. And then the Administration for Community Living. I now work as a contractor for ACL as a senior advisor here, and also working on some of their policy work. So my area of expertise, as many of you know, is Medicaid, Medicaid eligibility, Medicaid buy-in for workers with disabilities, and promoting employment and successful community living. So I look forward to working with this project and all of you, and thank you very much.
We are just delighted to have Annette here as our senior advisor, and we're really looking forward to working with you. So thanks for being a part of the DETAC, Annette. Grantees, participants, just want to make a formal announcement that if you do need a technical assistance request from one of our subject matter experts, please submit your requests on our portal. We are eager to help. A friendly reminder that this is free technical assistance from the DETAC. Next slide, please. As always, if you have any questions, please reach out to us via email to let us know if you have any questions. We have our website there, we have our contact information, and if you are seeking resources to help your work on moving the needle with competitive integrated employment, please look to the last link on that slide where you will see the DETAC publications. And then the last announcement that I want to make, just a friendly reminder, is that we have office hours, a continuation of this webinar planned on Friday from 12 to 1:30 Eastern Time. Dr. Mills will be on, Dr. Barawi will be on, and we'll also have Chris joining us. Daniel will be at work, so we won't have Daniel on. But if you have any questions or want to take a deeper dive into maybe a challenge or learning more about managed long-term services and supports, please join us by clicking on that Zoom link or call in. We'd be happy to hear from you and provide free technical assistance with our expert speakers. So thank you so much for all of you who joined us today. Thanks to Dr. Mills, Dr. Barawi, to Chris, and to our special guest, Daniel, for sharing your employment journey with us, for helping us understand how you were supported to obtain competitive integrated employment. So we look forward to seeing you on Friday, and we hope that you will also register for the upcoming webinar in March. Thank you so much, everybody. Have a great evening. Bye-bye.